So we'll talk about all the pediatric conditions for your benefit today. I'll try to be quick because we don't have all day. So first thing which you said is sepsis. So lots of children present to A&E with fever.
Yeah.
Okay, and not all of them are septic. So define sepsis quickly for me.
So essentially it's sepsis 6 we go by, at least in the adult population.
Uh-huh,
I don't know if that's
uh-huh.
appropriate for the child.
It's appropriate. It's sort of appropriate
Sure.
for children as well. And you have seen the new mnemonic. It's called Buffalo.
Buffalo, yeah.
Okay, so quickly go through what's Buffalo. B for?
I don't actually have the buffalo off the top of my head.
No, you don't.
Blood cultures,
Uh-huh.
and then urine output,
Uh-huh.
fluids,
Uh-huh.
antibiotics,
Uh-huh.
and oxygen.
And lactate.
Oh,
Okay, that's the L4. And we always check the blood glucose level in children. That's the thing not to be missed. So if you go through the ABCD approach, you look for the airway, check the breathing, circulation, and D is for dextrose in children. We always tend to check the glucose level, especially if they are smaller. So sepsis is basically infection in the blood, and that is serious. Okay? Lots of people will come to you with petechial rashes, and they equate it to meningitis. It's actually sepsis we are really worried about. If with sepsis they have meningitis, the outcome is actually better than if they have just sepsis without meningitis. So sepsis has to be taken very seriously. We have to, there's a golden hour, so you have to identify and treat them within an hour, and the outcome is much better if they have been given antibiotics within the first hour. So we have to identify those children. It's a bit tricky because everybody, as you said, will come with fever. And if you have a clear clause, especially with babies who have come with bronchiolitis, then we don't need to do anything. So it's very important that to differentiate between sepsis and bronchiolitis. So that comes with experience. It's not easy to differentiate between sepsis and, let's say, bronchiolitis, for example, which will need nothing, as opposed to sepsis, which will need maybe fluid boluses, antibiotics, and oxygen if needed. So you have to quickly make a judgment, if not escalate to somebody senior if you're worried about sepsis. And you take a blood gas, you take cultures, you start antibiotics if you're worried about sepsis. You can give a fluid bolus. So septic children will be tachycardic, and that will be disproportionate to the temperature. So with temperature, your heart rate is going to go up. So if your temperature has come down to normal and still the child is tachycardic, that's a bit worrying. So you have to take that into account. You also look for airway, that your airway is clear, make sure the breathing is okay, there's no crepitation in the chest, which might be a sign of lower respiratory tract infection. As opposed to viral induced wheeze, which is a very common presentation. And they can, it's as the name suggests, it's induced by a virus, not bacteria. So if they are a bit febrile, but they are wheezy, then you treat them as viral induced wheeze. You give them salbutamol, plus minus steroids if they are atopic. Okay. So that's one differentiating thing. The other presenting features might be a urine infection, in which case children do not complain of a dysuria or frequency or urgency. So if you have not got any other focus, you have to rule out a UTI. And getting urine sample from a baby, it's not easy. Okay, they will not go and give you a urine sample. It's a bit tricky, and as you all know. So you have to rule out urine infection. You have to rule out chest infection. Very often they may have a clear focus like a periorbital cellulitis or cellulitis anywhere else. Septic arthritis is also to be ruled out. So if you have a joint which is swollen, so you have to do a full examination. And don't be hesitant, don't be reluctant to completely undress the child to have a look throughout. You are also looking for rashes or any joint swelling, unless they have a clear focus like clear chest infection, or if they have periorbital cellulitis. So basically, to assess them, you do the ABCD approach, you do a full top-to-toe examination, you listen to the chest, you feel the tummy. It can be appendicitis, but it's usually present in older children and on the right side, but always do look for feel the abdomen if you can. Then you also rule out things like tonsillitis, which is quite common, and it's not easy to examine a child's throat, but make sure you do that because you don't want to miss tonsillitis, because that might be an easy focus to treat. And if it's a group A streptococci, then they will need antibiotic, which is very difficult to ascertain. But if the child is looking sick, if they have lots of pus on the tonsils, The good thing we have here is a point of care machine, which gives you a very quick and accurate full blood count and CRP in 5 minutes instead of 2 hours in the lab. So you can do a finger prick. The only thing to be mindful of is that CRP is the late marker of infection. So if you have a 1-day history of fever, your CRP may not be that raised. So if the fever has been ongoing for 3 to 4 days, then CRP will be a good marker. If it's low, if your white cell count is showing lots of lymphocytosis or lymphopenia, that's a sign of viral infection, in which you can reassure, ask the parents to continue ibuprofen paracetamol. It's a good way to judge once you have given them ibuprofen paracetamol here, and if the child settles down, you can re-examine them and make sure they have, now the heart rate has returned back to normal, they have taken some feeds, then you can reassure and send them. But all obviously give clear red flags. So make sure they are aware that if the child becomes sleepy or lethargic, or they're continuously vomiting, not keeping anything down, if the urine output has dropped, or if they develop a non-blanching rash, which is usually pinpoint, and if you press on it, it doesn't go away. It can start with the blanching rash, and then I've seen it converting into a non-blanching rash. So you have to warn the parents about that. If they are febrile despite ibuprofen paracetamol and looking ill to the parent, always be mindful of that. The parents know their child, they have seen them before, and despite giving ibuprofen paracetamol, if the child is looking unwell, then you treat it serious. Any questions?
In terms of fluid bolus, how much fluid?
So normally we start with 10 mils per kilo.
Okay.
Unless the child is looking very dehydrated, you can make a call to give 20 mils per kilo. But usually we start with 10 mils per kilo and reassess. And after 10 mils per kilo, if the child has perked up, then fine. If they are still looking dry, dehydrated, then you can give another 10 mils per kilo. And make sure it's always either isotonic or hypertonic. Never given hypertonic fluid like 0.45% saline. It has to be at least 0.9% saline. Okay, but yeah, start with 10 mils per kilo. We normally tend to use ceftriaxone. If you're not that worried, 50 per kilo. If you're very worried, then 80 milligrams per kilo, especially for meningitis or serious bacterial infection. The only thing is for babies, which you'll probably not be dealing with, we use ceftriaxone instead of ceftriaxone. But yeah, otherwise ceftriaxone is a good broad spectrum third generation cephalosporin, which will cover most gram-positive and gram-negative bacteria. So fluid bolus, ceftriaxone, gas to show your lactate, oxygen as required, or Optiflow if needed. Okay, if they are having respiratory difficulty, maybe get a chest X-ray. If you haven't got no focus, make sure you get a urine sample.